All right, so as usual, please everyone participate so I don't have to call on people and startle them out of cuddling with their cats or their kids or eating your oatmeal, whatever. All right, so please choose a correct statement regarding lung cancer. So 5-year survival rate for all lung cancer patients is 18%. Is that true?
Yes.
Yes.
Unfortunately, that is absolutely true. Lung cancer, even though we keep making great strides with new drugs, and these new drugs in many cases are really increasing progression-free survival, one of the things that is still not changing is this overall survival. This is reflective in the fact that it's the second leading cause of death among cancer patients. So hopefully over time, the more research that's done, if we can potentially even start giving patients therapy even earlier, as opposed to just surgical therapy, chemoradiation, maybe some of these rates will improve. So is there an effective screening tool for lung cancer?
Yes.
Yeah, there is. What is it?
Helical.
Low-dose helical.
Helical CT.
Yep, exactly. A low-dose helical CT scan. And basically what that means is it just kind of does a quick number of pictures and creates a 3D image. And we're able to actually see if any parts of the lung are affected by lung cancer, because people don't typically have symptoms until they're like fairly late stage, right? So this is another example of the earlier we catch it, the more effective our interventions are. 80% of lung cancers are detected in the advanced or metastatic stage. Is that correct?
That's 66% or 2/3.
Exactly. 2/3. So it's still really too high, right? But at least it is improving, because it used to be the patients were pretty much only being diagnosed in the advanced or metastatic stage when they finally had symptoms. And then non-small cell lung cancer and small cell lung cancer are equally prevalent among patients.
No.
Thankfully not, because small cell lung cancer, despite the fact that it responds really, really well to chemo, it tends to kill people very quickly. So unfortunately, one of the areas that it really likes to metastasize to is the brain. And that's one of the reasons why we do whole brain radiation, and we combine with really toxic chemotherapies like carboplatin, etoposide. So unfortunately, again, with non-small cell lung cancer, we have more therapies available. And I think we're getting a better handle on how to potentially increase overall survival. Small cell lung cancer, we still really don't have a great handle on it. Okay, so for question number 2, see if it'll, yep. So TD is a 64-year-old transgender male who has worked in construction for the past 45 years. I left it out, but the last 15 years or so, he's been doing radon testing and remediation for buildings in a rural part of Northwest Connecticut. He smoked since he was 16 years old and now has very well-controlled COPD. He had early-stage breast cancer at 50 years of age, where he received radiation as well as a bilateral mastectomy. So how many risk factors does TD have for lung cancer?
4.
That's right. Yeah, so can you tell me what they are?
The radon testing, and number 2, COPD. He smokes, and he was treated with radiation.
Right, specifically radiation to the chest, right? That's what we're concerned about. So if I had said, a patient had osteosarcoma and in the leg and had radiation to the leg, that wouldn't necessarily increase the risk. But we do know that any kind of DNA damaging, agents or environmental factors can definitely increase your risk of lung cancer. And in this case, the patient has multiple risk factors. And that is very common in patients who are diagnosed with lung cancer. So it's not just necessarily that they were a smoker or that maybe they lived with someone who's a smoker, so they had secondhand smoke. But they're usually, it's kind of multifactorial. Does anyone remember what some other risk factors for lung cancer are, besides all of these?
Genetic problem.
Mm-hmm. Yep. And what else?
Environmental tobacco exposure. Other. Sorry, we already went through that.
Yep. You were on something. What's
asbestos. Asbestos.
Yes, asbestos. So, it's something that doesn't really get a lot of press now. But unfortunately, there are a lot of people who have been exposed to asbestos, especially people in construction, people putting in insulation or doing plumbing, heating, things like that. And what's interesting about asbestos exposure is that when people inhale asbestos, it starts off this whole immune response in the lungs, and that immune response is what eventually damages the lungs and usually triggers those multiple hits to occur. Patients will typically either get some kind of lung cancer, like small cell lung cancer, or they'll get something called mesothelioma, which is a different kind of lung cancer. And it can actually occur in other organs as well. So, we see a little bit less of this as the people who worked with asbestos unfortunately pass away, because asbestos is now very much limited. It's not allowed in new buildings, and usually there's some kind of remediation that they're requiring to get rid of asbestos. Now for radon is actually a really big issue in the Northeast. Or any area that has a ton of farmland, right? So we're actually in an area that probably has quite a bit of radon when people build homes on top of what used to be farms. So it's a naturally occurring substance, but it does tend to concentrate in areas that are like old farmland. So for any of you who, when you go out and buy a house someday when you're super wildly successful pharmacists, and I can't wait for that day, it's going to be very exciting. And you actually are doing some of the inspections, make sure that you request a radon test. Because again, that's something that it's cheap and easy to do. And if you have to do a remediation, all they do is they basically stick a little pipe down a certain number of feet into the ground, and they vent it out so that the radon can literally leave your house. Because most radon is concentrated actually in the basement. So you probably learn more about radon than you ever wanted to, but it's important because it's probably one of the most influential and impactful reasons why we have such high rates of lung cancer, and not necessarily just smoking. All right, any questions? Okay, so patients with non-small cell lung cancer often have tumors that carry an EGFR or ALK mutation and PD-L1 overexpression. Is that true or false?
True.
It is true. It's true because we have a ton of drugs, right? So if we didn't have all these mutations, we wouldn't have a ton of drug targets. So that's why, at least with non-small cell lung cancer, and I told you that there are 4 kinds, but we're really only focusing on 2 of them, non-squam and squam. But for the non-squam, we do see a ton of these mutations, especially. Okay.
So under these, sorry to interrupt, under the EGFR, AKLA, you just want us to be able to recognize what drugs come under each mutation? Exactly,
yeah, exactly. Because again, this is something that, between, so Naplex really likes to test the TKIs for some strange reason. And the problem is that there are more and more of them coming out every day. So at some point, we're going to run out of test questions for everyone. But they do like to focus on the lung cancer TKIs. And so one of the things that they want you to know is not necessarily the deep detail of their MOAs, because they're complicated, but just essentially what mutation goes with what and what are some of the common major toxicities that patients might deal with. All right. So did that answer your question?
Yes.
Okay, I just want to make sure. Okay, before I moved on. All right, so AJ is a 52-year-old African-American cisgendered female with newly diagnosed inoperable stage 3 non-small cell lung cancer and has PD-L1 expression of less than 25%. I don't know why I had a question mark. Sorry. Which of the following options is most appropriate for AJ? So which one do you guys think?
A.
That's right. And that's based on the Pacific trial, right? So this represented a major shift in practice for us. Like, honestly, when the Pacific trial came out, I sat in my chair and I cried with tears of joy, because being able to give a stage 3 cancer patient, lung cancer patient, 11 months of progression-free survival without having to do like some of the toxic consolidation chemos. So for example, when we do chemoradiation, I'm not saying that that's not toxic. It's an awful experience. We're combining a platinum, usually cisplatin or carboplatin. We have a couple of different options of how we give it. We can give small doses weekly of the carbo or the cis, or concurrent with the radiation, or we can give bigger doses of the carbo or cis every 3 weeks concurrent with radiation. So there's a lot of toxicities, but traditionally we used to do the chemoradiation and then we do what's called consolidation therapy with more rounds of cisplatin and Taxol or carboplatin and Taxol, and obliterating patients like, bone marrow and causing all kinds of neuropathies, neurotoxicities, nausea and vomiting that just, or just underlying baseline nausea that just persisted for months. We were doing really awful things, but we were trying to prevent it from going to stage 4. We were trying to prevent it from advancing. So when durvalumab or Imfinzi came out as being like this kind of game changer for patients, this is really exciting. So again, the Pacific trial is, I know you guys don't have time to read it, but at some point, I encourage you to read the Pacific trial because it's a really elegantly done trial. And the data from it was just incredible. Because again, when we talked about prostate cancer, when I was talking about overall survival, we're talking about maybe a couple of months. Now, granted, this isn't overall survival, but we know that if we increase the progression-free survival by 11 months, then we are, more than likely also affecting overall survival data. So anyway, this was a really important study. And it's exciting. And it also means that we may have other immunotherapy options that we can start using earlier in advanced instead of metastatic lung cancer. And we are definitely seeing that for Pembro and Nivo as well, and sometimes even the combination of nivolumab and ipilimumab. So we'll see where that leads. But right now, the recommendation is durvalumab. Any questions on that? And you guys remember, what is durvalumab's mechanism of action?
PD-L1 inhibitor.
That's right. It's an anti-PD-L1. So what are some of the kinds of side effects I need to worry about from these drugs?
All of the itis?
Yes, all of the itises. Exactly. So name a couple of itises that are, well, one itis in particular that's going to happen to 100% of patients who take any of these PD-L1 anti-PD-1 inhibitors.
Pneumonitis?
What was that?
Pneumonitis?
Oh, I hope not. Pneumonitis is a very, very bad one. But you're getting closer geographically.
Colitis?
Move
Hypothyroidism?
up. Move up. Yes. Who said hyperthyroidism or hypo?
Oh.
Yes. I think I heard somebody say hypothyroidism. So you're right. Colitis can definitely happen. I was thinking more moving up geographically on the body, like closer to the thyroid. So remember that for patients who receive any of these immunotherapy agents, they're going to probably have some kind of a thyroid flare initially, because the thyroid is very, very sensitive to any kind of changes in your immune system. In fact, there are plenty of viral infections or bacterial infections like strep that can ignite a kind of Graves' disease-like phenomenon for patients. So the thyroid is super, super, super sensitive. And that is no different when we give patients immunotherapy. So give them immunotherapy, they become hyper for maybe a short period of time, and then everybody eventually has to go on levothyroxine or some kind of replacement because everyone will become hypothyroid. So if you can remember that, that's an important one because a lot of clinicians who are newer and don't know about, this is a normal side effect. It's just part and parcel of giving immunotherapy. All right, good job. Any other questions about this?
Dr. Levis, since we know it causes hypothyroidism, can we pre-treat them with like levothyroxine or something before?
So we want to wait until their levels become abnormal because, and that's actually a really good question. One of the problems with treating thyroid is every person is so different in terms of how they experience either like high TSH or low TSH. So ideally you want to intervene before someone has severe problems, right? Because we don't want someone to go into like a thyroid storm or myxedema coma. But in general, once I start to see that TSH rise and, they maybe start complaining a little bit of like, oh yeah, I got a little bit of dry skin or I feel a little bit more tired. At that point, once their TSH is abnormal or it's starting to trend abnormally and they have symptoms, then we give them the levothyroxine. And I would say on average to start, it's probably within 2 months after they start, maybe 3, like 40% of the patients by that point are going to have to start levothyroxine. So it definitely happens within like the first 6 months of treatment. Great question.
So if they're stage 3, so we're only going to give them durvalumab. Are we going to give them anything else after that? Or let's say, you put stage 3 in a question and that's the only option for stage 3, or we have other options?
Well, we have some other options, but this is so the caveat to this is if someone does not progress on the chemoradiation, then once they complete that, then they can go on to durvalumab. If someone, if their disease worsens when they're on chemoradiation or being treated, then we have other alternatives and we may shift to those. And some of them may involve just like changing up the chemotherapy, maybe adding an anti-VEGF. There's a whole host of scenarios that can happen. But for our purposes, just to try to keep things as simple as possible, because the non-small cell lung cancer guidelines, they're actually separated out into, there's one for non-small cell and there's a separate guideline for small cell because they are so divergent. And those guidelines are 240 pages. So in order to not like make everything crazy, just know that the Pacific trial changed our ability to, to just give patients chemotherapy. We're actually able to give them immunotherapy earlier before they're metastatic. So that is the extent of kind of what I want you to know. So I'm not going to ask questions that are very divergent from these questions because these are the basic concepts I want you to be able to identify. Are you satisfied with that answer?
Yes, that's fine. Because the reason I was asking is we have a lot of, mutations, and then in stage 4 we have so many different types of drugs that we can give, and we have to know what mutation they have under stage 4, and then we can give them that. So that's why I was like, okay, so under stage 3, what would you be able to give them? So I was thinking that way.
So in general, this is kind of our mainstay. Now, if somebody who has stage 3, inoperable stage 3 lung cancer does have a mutation, once they've completed the chemoradiation and durvalumab, we may, like if they have an EGFR or ALK mutation, we may also then put them on a TKI to basically be on indefinitely to help prevent that transformation to stage 4. So in general, just, for you guys to kind of have a basic awareness that we do surgery, chemoradiation in pretty much stages 1 through 3 and some combination thereof. And then when you get to stage 3, if you're not, again, you're inoperable, then we will give you systemic treatment. And more than likely, if you have some kind of mutation, we will treat that also, because we do expect that a stage 3 person at some point will convert to stage 4.
Oh,
So,
okay.
Mm-hmm.
Thank you.
Yeah, no problem. That's a great question. I'm trying to simplify things as much as I can. And that's, it's a little bit tough because you're absolutely right. There are a lot of permutations for how we can treat these patients. But for our purposes, I'm going to make it really clear. So there's going to be no ambiguity at all, I promise. Okay, so a patient, and actually you're bringing us to the next question. A patient with metastatic non-small cell lung cancer and an ALK mutation should be prescribed which of the following?
Alcensa.
That's right, Alcensa. And what is the other name for it? What's the generic name for it?
Alicitinib.
Yes, and it's much easier to pronounce than some of the other ones. I don't know where they came up with some of these, but so what do we use? Tagrisso, Aressa, what target is hitting that one?
EGFR.
Mm-hmm. What about Mechanist?
The MEK pathway.
Yeah, and what's the other name for Mechanist?
Trametinib.
That's right. Where do we see that drug?
Colorectal cancer.
That's right. So remember I said that some of these adenocarcinomas have a lot of similarities between organ systems. So if you notice, we've seen like BRAF mutations, right? We've already talked about KRAS, NRAS mutations, and EGFR mutations. That's really, when we talk about EGFR mutations in lung cancer patients, that's what we're talking about. You've got some kind of NRAS, KRAS mutation within that EGFR family. So what we know is that these epidermal growth factors and some other related kind of family members are expressed on epithelial cells. And epithelial cells are all over your body, right? They rapidly proliferate. They're designed to replace themselves quickly because they're usually in areas with like a lot of motion or a lot of activity, like the gut and the lungs. So that's one of the reasons why we have a lot of overlapping mutations that can occur in lung cancer and lung cancer and colorectal cancer. Interestingly enough, I didn't really talk about this so much in colon cancer, but there also are HER2 mutations as well, and we're starting to use trastuzumab, things like that. We also potentially, there may be some use for them in lung cancer as well. So we're starting to see that a lot of these drugs that were initially approved for a particular indication may have some activity in these different kinds of cancers. So that's exciting. All right. Awesome. Thank you guys. And I really appreciate everybody being participatory. That's super helpful. Okay, so please choose the immunogenicity of the following agents. So what is paclitaxel? Is it highly, moderately, low, minimal? It's a low, right? And what's that percentage for low?
Less than 10.
10 to 30.
That's right. And what about cisplatin, 100 milligrams per meter squared?
High.
Absolutely high.
High.
Absolutely. And carboplatin, AUC of 3.
Moderate.
Moderate.
Mm-hmm. Yep.
Moderate.
And in some patient populations, maybe high, right? Vinorelbine, which is kind of a new drug for us, right? It's a Vinca.
Minimum.
Minimal.
Mm-hmm, exactly. It's interesting that all the Vincas are minimal, right? Like you probably don't expect, when we talk about Vincas, we talk about how like neurotoxic they are, and you can't give them intrathecally, and we make them like scary, scary drugs. But from like a other kinds of side effect perspective, they're actually fairly well tolerated. And what about durvalumab?
Minimum.
Right, minimal as well. And crizotinib.
Moderate.
It's a moderate, that's right. And that's really important because unfortunately, when patients get prescribed a lot of these TKIs, providers forget that they may cause moderate emesis, and so they might not remember to give somebody Zofran or something else to have on hand. or to take daily when they're taking this drug so that patients don't become nauseated and vomit. Awesome. Any questions about this before I move on? All right. So this one was just a straight up memorization. So TQ is a 55-year-old African-American female with stage 4 non-small lung cancer and is beginning on Alimta. What's the other word for Alimta? Or the other name?
Methotrexate.
That's right, pemetrexed. Her oncologist wants to know what pre-medications and concurrent medications she should prescribe. So please select the correct statement. So which one was right? Mm-hmm. Exactly. So one of the things, one of the things that is controversial about pemetrexed right now is this like timing of vitamin B12 shots. So a lot of institutions are now saying, you know what, we're not going to do the 7 days before, even though that's the package insert. Instead, we're going to maybe do it with the first dose. We'll see kind of how that shakes out, but primarily they're doing it just for patient, convenience. So patients don't have to come back or show up to clinic like a week before, because it usually has to be a separate appointment. And then why do we give the dexamethasone when we do give it correctly, obviously? What does that help prevent?
Rashes?
That's right, rashes, and sometimes a little bit of edema that goes with the rashes as well. Yeah, so this is a big problem with pemetrexed. It's interesting because it's related to methotrexate, but we really don't see the rashes with even high-dose methotrexate. So there's definitely something a little bit different about that drug. All right, any questions on this before I move on? Okay. So DT is a 66-year-old, everyone's African-American today. That's just how it shook out. With stage 4 non-small cell, her oncologist wants her to begin on crizotinib. What would you counsel your patient regarding her crizotinib? We just talked about it, right? So
Antiemetic.
Yep, exactly. Now, which of the drugs requires monitoring of CPK?
It's L-citinib, one of them.
Sorry, say that again.
Was it L-citinib? Was one of them?
Yes. Yep, that's the one. So between the two of them, so crizotinib tends to cause more ocular toxicity, but Alcenza has this really significant risk of CPK. Of rhabdomyolysis and muscle breakdown. So we really want to make sure that we're checking that regularly, and that we let patients know if they have any muscle tenderness, weakness, things like that, that they need to call a provider immediately. So that's kind of one of the weird side effects that we don't really see with a lot of the other TKIs. It really seems to be just specific to Alcenza. All right, awesome. So your patient recently started on platinol and navalbine. What serious ADR should you monitor for?
Constipation and otic. Platinol will cause the otic, and then the navalbine would cause, I think, constipation.
That's right. And do you remember the mechanism for the constipation? Because it can be really, really bad.
Is it due to neuropathy?
It is, exactly. So it's almost like a gastroparesis. So if you think about, and I've mentioned this before with the taxanes, anything that affects mitosis, one of the main side effects, so if you forget kind of like all the other side effects and mix things up among all the different drug classes, if you can remember that anything that affects mitosis often will also cause some amount of neurotoxicity, because it affects the way tubulin moves. It affects the way muscles and nerve cells are actually able to communicate with each other. Your gut is highly innervated, right? That's how you have peristalsis. That's how you are able to like kind of have that involuntary muscle move all the food down and then be able to evacuate it. What Vincas do is they fundamentally disrupt that process, and so essentially causing gastroparesis in patients. One of the things that's really dangerous about Vinca-related constipation is that it's not responsive to Senna or some of the other drugs that we have available. So what can happen is that patients can actually end up with bowel obstructions or bowel perforations. So we really want to take this very, very seriously. And fiber and all this other stuff, it's not necessarily going to help. So, one of the things that we try and do is if we can prevent it from becoming serious enough by encouraging people to use stimulants at the first sign of constipation and to tell us as soon as they're constipated, we will often actually take the Vinca off. And not even dose reduce it. We'll just switch it out for something else, because that really is a very serious event if it happens. It can cause other kinds of toxicity, like other kinds of neurotoxicities as well, vestibular ones also. So some people will have problems with ataxia, but generally speaking, it's really like concentrated in the gut. And then ototoxicity, we know that cisplatin is also neurotoxic. So you're combining two neurotoxic drugs together, which means you get often much more neurotoxicity, unfortunately. Awesome. All right. We also talked about this. So while a patient is on alectinib, what should you monitor for? Or what should you monitor? Select all that apply. So what do we need to watch out for in these patients?
LFT.
Yep, LFT because of hepatotoxicity. What else?
Heart rate.
That's right. And why do we watch out for heart rate, or why do we want to monitor that?
Because it could cause bradycardia.
Exactly. It can cause bradycardia, and sometimes it can also cause other kinds of arrhythmias that could be fatal. So in some of these studies, there were grade 5 events, and they were mostly cardiac events. Exactly. What about blood sugar? Yep, hyperglycemia. Are you noticing a trend with these TKIs that they have weird side effects, right? And the side effects don't seem to have the same kind of pattern of making sense that some of the chemos do. And it's because, again, a lot of these kinases affect many different organ systems. Okay, so we know blood sugar, LFTs, so blood sugar, hyperglycemia, LFTs for hepatotoxicity, heart rate for bradycardia and other electrical abnormalities. And then what about vision? Yep. So It's not, right, exactly. So it's not as toxic to the eyes in the same way that crizotinib is, because that we actually denote as like ocular toxicity. But we do know that vision changes can happen, and we do want to watch out for that. And then what about PPD? What do we use PPDs for?
What
was that?
The TB.
Yes. Sorry, I heard baloney because I'm technically in my laundry closet right now, so everything's like echoey. Yeah, so TB. Well, we don't really. I threw this one in just to kind of just for kicks and giggles, but we don't actually need to monitor TB necessarily on these medications. However, in patients who are being worked up for lung cancer, we absolutely do want to check a quantiferon or, a PPD if it's appropriate to make sure that somebody doesn't have latent TB. Because if they do, whenever we give them chemotherapy, that could potentially reactivate their TB because we're suppressing the immune system. So that could be something that's used in initial workup, but definitely not for monitoring this drug. Awesome. All right. So does anybody have any questions before I stop sharing my screen? Or,
PPD is not included, right?
What was that?
The PPD is not there.
No. I was just messing with you guys. Yeah, no. PPE is an extraneous one. Yeah. Awesome. Okay. Very cool. So, wow, we only got 63 of you today. People must